the questions described. So it has to be subdivided into magnesium regulation in the body, the normal actions of magnesium, which important. Then aberrations in magnesium balance, that is hyper and hypo, and finally use of
Anesthesia.
magnesium in anesthesia. So subdivide the answer into that, and the common cation after sodium, potassium, and calcium. This is the fourth most abundant. And it is mainly intracellular. So after potassium, it is the most common intracellular ion. The serum level is very low, 0.7 to 1 millimole or 0.7 to 2 milligrams. And it's about sources where it is found, it's all mentioned nicely there. And 1/3 of the dietary magnesium, how it is absorbed and how the balance is maintained in the body is mainly from the dietary sources, absorbed from the small intestine, and to some extent from the large intestines also. And the dietary intake is about 15 millimole. And the balance is maintained mainly by the kidneys. If there is a decrease in that, reabsorption occurs from the ascending limb of lipofenily and usually excreted by kidney if it is in excess. Parathyroid hormone also has a effect on the effort to absorb it, and aldosterone causes increase in renal excretion. And chronic magnesium deficiency will result in depletion of body store, but plasma concentration may be relatively normal even if the patient has got decreased intracellular levels. So that is a very tricky situation there. So you cannot go by the serum level alone and assess the total body magnesium level. So, but if there is a reduction in the plasma level, that indicates that there is a definite total reduction in total body magnesium. And what are the main functions? It establishes the electrical potential across the cell membrane, and also involvement in the sodium potassium ATPase system. And it is very useful in biosynthesis of DNA and RNA, protein synthesis, and production of ATP. So it is very important. And its effects on calcium metabolism and production of the cyclic adenosine monophosphate (CAMP) is magnesium dependent, and it controls the release of parathyroid hormone. And deficiency of magnesium is often associated with hypocalcemia. So low magnesium will always be associated with low calcium also. And intracellular magnesium inhibits calcium influx through calcium channels. And the physiological antagonist to calcium, that all of you know that. The physiological antagonist to magnesium is also calcium. So whenever you give excess dose of magnesium in preeclampsia, if the dose increases and it produces toxic effect of magnesium, to counteract that, you give calcium. So it is vice versa. And the actions on various systems we described: cardiovascular system, direct depression effect on the myocardium and the vascular muscle, and inhibits the catecholamine release from not only adrenal medulla but also at the peripheral adrenergic terminals, directly blocks catecholamine receptor. And it, as a result of this, cardiac output and vascular tone are reduced, and hypertension, there will be a decreased PVR also. As an antiarrhythmic agent, slows the rate of impulse formation at SA node and prolongs SA conduction. So PR interval and AV nodes become are in refractive period. So which nerves are controlled, especially towards this point. All of you know that that is choice. And the nervous system reduces the acetylcholine at the neuromuscular junction, causes reduced excitability of nerves, and they also act as an anticonvulsant, and reverses cerebral vasospasm. It's a very important action on that. And in the musculoskeletal, it relaxes the skeletal muscles, and in combination, can cause muscle weakness also. The respiratory system produces a bronchodilatory effect. The sedative can be used in refractory asthma, and respiratory failure may occur as a result of excessive muscle weakness. And the genitourinary system is a powerful tocolytic, decreases uterine tone and contractility, produces mild diuretic effect. Physiological system, platelet activity is reduced, resulting in prolonged bleeding time. And disorders can be hypo or hyper. In hypo, the levels become less than 0.7, and it is usually because of nutritional deficiency and susceptibility to hypomagnesemia when there is a increase in demand during critical illness and recovery. And causes are can be either due to decreased intake from the gut or increased loss from by the kidney or altered redistribution. The causes are all given here. And the clinical features, anorexia, nausea, muscle cramps, etc. And later, it may be hyperirritability, hyperexcitability, spasm, spider, tetany, all these things can happen just like in calcium. And the hypertension is common and pulmonary edema also can happen. ECG may show a prolonged PR and QT interval, and it can result in ventricular or supraventricular arrhythmias also. And the cluster strain and trouser strain also can be elicited in this case, and it will be usually associated with hypokalemia due to urinary potassium losses. The hypocalcemia will also be there, and it depresses both intra and extracellular potassium. The management of hypomagnesemia depends on the severity and clinical status. Normally requires 10 to 20 millimoles per day is the normal requirement. You can replace it according to the severity by either oral or by parenteral route. And chronic deficiency can be corrected with 40 to 80 milligrams. All of you should be aware that PCR preparation usually comes as a 50% solution, that is 2 ml ampules. And causes of hypermagnesemia is hydrogenically, it is due to excessive antacids and purgatives that are taken, and diabetic ketoacidosis and tumor lysis syndrome also this can happen. The clinical features are headache, nausea, vomiting, initially diarrhea and hypotonia, neuromuscular block. So both hypo and hyper cause muscle weakness. So that is the strange thing that is happening here. And hypotension and bradycardia are at higher levels. And the ECG is very, very classical in hypermagnesemia. So there is a PA is becoming flat, and the pre-R interval is prolonged. 2RS complex will be widened. There will be a tall T wave. These 4 features have to be mentioned in the ECG, which is quite diagnostic. And the various systems that are affected based on the serum level are, when the level is at 4 to 5 millimole, muscle weakness is there. 5 to 7, it will produce respiratory paralysis. 10 to 12, cardiac arrest. So this point is commonly asked in the Viva for when you use magnesium for pre-eclamptic patients. The common question the examiner asks you is, what are all the various serum levels producing effects on the various systems? So 4 to 5 millimole muscle weakness, 5 to 7 respiratory paralysis, 10 to 12 cardiac arrest. So you must remember. And the management of hypermagnesemia can be prevented by anticipation. So avoid taking all medications or the food that contain magnesium. And if renal function is normal, then fluid therapy and diuretics can be given. But usually in patients with renal failure, this will get aggravated or exaggerated. So they may require hemodialysis or filtration in renal failure. And in emergency hypermagnesiemia with ECG changes, IV calcium gluconate 2.5 millimoles can be given intravenously to immediately set right the balance. And the uses in anesthesia, the cardiovascular system, it may precipitate arrhythmias, so that has to be corrected with magnesium and then taken up. And it may cause, so patients who are on magnesium therapy for preeclampsia especially, after give GA, we have to be quite careful that it may cause a sudden crash in the blood pressure by causing a severe hypertension. And it should be avoided if there is a conduction block. And it may be effective in treatment of this particular like exhausted response and digoxin induced and ventricular arrhythmias which are unresponsive to treatment. You can use that. The dose is 2 grams over 10 minutes. And in shock refractory ventricular fibrillation also, you can use this for correcting the. And actually, when you try to do this, it does not interfere with any action of the endogenous adrenaline or epinephrine. And it's used for surgery in phaeophromatocytoma and also suppression for BP during the handling of the tumor. And the dose for that is 40 to 60 kg and 2 hours per hour infusion. And caution should be used when the patient is already on calcium channel blocker. Usage of magnesium, especially if you are going to use it for as a component of opioid-free anesthesia, and patient is already on nicotine or amlodipine, we be wary of using this because that may cause an exaggerated hypotensive effect. And the effect on nervous system, preeclampsia and eclampsia, it is one of the main drugs for preventing seizures. And it's a drug of choice even if the patient throws a fit also, they will don't give a phenytoin or barbiturate like normal seizure control. Here we use magnesium sulfate. And it can be used for suppression of pressure response during laryngoscopy and intubation. And also it is a part of opioid-free analgesia. Also it is used in chronic and neuropathic pain treatment as a part of the therapy. And it has to be used in caution with patients with myasthenia or muscular dystrophy. Tetanus, it is one of the drugs that can reduce the muscle spasm because of its effect at the neuromuscular junction. But again, the complications are hypotension, bradycardia, all those things have to be taken care of. And the dosage is 5 grams magnesium IV followed by 2 grams. And then the respiratory system dilates bronchial and pulmonary vasculature, so it can be used for refractory asthma. In CPB, usually hypomagnesemia will be there and that has to be corrected. And calcium channel blockers and magnesium, they will potentiate the action of nicotine, so it has to be used with caution. About magnesium, both of us have prepared the answers from the